Let's jump right in. When you think about medicine, right, your mind probably goes straight to a doctor's office. A physician treating one single patient sitting on an exam table. But what if we zoomed way out? Today in this explainer, we're looking at what it actually takes to treat not just one person, but an entire society. And we'll see why studying health across massive populations is literally one of the most powerful tools we have for saving lives.
To really wrap our heads around this, we've got to start with a famous story in medical sociology from Irving Zola. It perfectly captures the downright exhausting dilemma of modern medicine. Imagine you're standing by a fast-flowing river, and you hear a drowning man cry for help. Obviously, you jump in, pull him to shore, and give him CPR. Phew, right? But just as he starts breathing, another person floats down, yelling for help, so you jump back in. Then another, and another. It's completely overwhelming. As Zola put it, I am so busy jumping in, pulling them to shore, applying artificial respiration, that I have no time to see who the hell is upstream, pushing them all in.
That story, it absolutely hits the nail on the head when it comes to the core tension in healthcare. Pulling people out of the river, that's what we call our downstream approach. It's clinical treatment, urgent care, focusing entirely on an individual's immediate needs. And don't get me wrong, it is absolutely vital, life-saving work. But the upstream approach, that's about taking a walk up the river. It's about prevention, social intervention, and figuring out the economic and political factors that cause people to fall into the water in the very first place. So let's take that walk upstream. Section 1, the zoom-out approach. So, medical science basically operates on this fascinating, almost ladder-like hierarchy. Down at the absolute smallest scale, we're looking at molecules. That's molecular biology. Then we zoom out a bit to cells, then out again to organs and entire systems, which is physiology. Zoom out one more level, and we're looking at individual people. This is your standard clinical medicine and psychology. But if we zoom out one final time, we are looking at entire populations. And it's at this macroscopic level where we finally get the perspective to see those upstream forces at work. Section 2, defining the upstream sciences. So what are the sciences that actually study this? First up is public health. Back in 1988, Donald Acheson gave us this classic definition: the science and art of prolonging life, preventing disease, and promoting health through the organized efforts of society. Now pay attention to that very last phrase, the organized efforts of society. Public health doesn't just rely on a single doctor. It brings together sociology, economics, environmental science, and public policy to take this sweeping, population-wide view. It's literally about redesigning society so that the river is just safer to walk beside. The second key discipline, and really the engine that makes public health work, is epidemiology. We define this as the study of the distribution and determinants of disease in human populations. Think of it this way. If public health is the car trying to get us to a safer society, epidemiology is the GPS. It's super quantitative, it asks the hard questions. How frequent is this disease? Exactly who is getting it? And most importantly, why are they getting it? It hands us the raw data we need to pinpoint exactly what those upstream pushers are. Section 3, visualizing inequality. Now check this out. This is a map of the London Underground's Jubilee Line, but it's actually a stunning visual representation of health inequality. When we look at population data, it reveals that neighborhoods literally just a few miles apart can have drastically different life expectancies. As you travel east from Westminster down the Jubilee Line, on average, each stop represents nearly 1 full year of life expectancy lost. No way, right? But it's true. A man living near Westminster expects to live to nearly 78, while a quick train ride away in Canning Town, that drops to almost 70. You can never see this by just looking at one patient in a clinic. You can only see it by zooming out to the population level. So, what on earth explains that massive gap on the Jubilee Line? Well, it all comes down to the determinants of health. These are the biopsychosocial factors. Sure, your age and genetics definitely play a big role, but as we zoom outward, we start seeing individual lifestyle choices, social networks, and here's the big one, living and working conditions. We're talking housing, clean water, sanitation, education, and then finally, the broader socioeconomic and cultural environments. These layers, they are the literal hands pushing people into the river. Section 4, measuring health, the hang gliding trap. Okay, I want to throw a real scenario at you. This was actually published in the British Medical Journal back in 1978. Between 1973 and 1976, there were 75 hang gliding accidents, and the data showed that the vast majority of these crashes happened between 11 a.m. and 3 p.m. So, the seemingly logical conclusion was, hey, we should ban flying between 11 a.m. and 3 p.m. to avoid the danger. So, what's wrong with this reasoning? Take a second to think about it.
Did you spot the flaw? The problem is we only have the raw number of accidents, the numerator. What we are completely missing is the denominator, or what epidemiologists call the population at risk. You can't just count the crashes. You have to know how many people were actually up in the air flying during those hours to begin with. Think about it. If 90% of all hang gliding happens between 11 a.m. and 3 p.m., then of course most of the accidents happen then. Without connecting the events to the total population at risk, those raw numbers are, well, pretty much meaningless.
To avoid falling into that hang gliding trap, epidemiologists rely on some highly specific rates. Here are the big three you need to know. First, the incidence rate. This tells us how many new cases are popping up in a specific time frame. It's fantastic for checking if a new prevention strategy is actually working. Next is the prevalence rate. This counts all current cases, both new and old. This one's absolutely crucial for planning things like hospital beds and healthcare resources. And finally, the mortality rate, which simply tracks the rate of deaths. But remember the golden rule for all three. You absolutely must divide by the population at risk to get the real story.
Section 5, the payoff. Why population health matters.
So why does all this matter? It matters because understanding epidemiology completely transforms a doctor from just a biological mechanic into a holistic healer. Doctors are really expected to take on a much broader role in society today. First, to advocate, using this hard, quantitative data to raise awareness about those upstream issues. Second, to mitigate, meaning doing what they can within their clinics to buffer the harsh impacts of poverty and deprivation. And third, to collaborate, teaming up with other sectors like housing, education, and community groups. Because let's face it, a prescription for antibiotics isn't going to cure a chronic cough if the root cause is a damp, moldy apartment.
When we combine the essential downstream care of clinical medicine with this wide upstream vision of epidemiology and public health, it's like a superpower. We finally get the ability to not just save the drowning person, but to walk upstream and build a fence. So I want to leave you with this question. Take a look around your own neighborhood. What are the invisible upstream factors? Maybe it's the housing, the transport, or the local environment that are quietly shaping the health of your community right now. Thanks for joining me for this explainer, and keep asking those big questions.